Hello, my name is Aaron Himmler. I'm the Associate Athletic Director for Sports Medicine and the Head Football Athletic Trainer at the University of Cincinnati. It's an honor to take part of the 10th Annual Southwest Conference Athletic Trainer Summer Seminar. I really appreciate the opportunity to present about a unique case that my staff and I experienced in one of my previous athletes. And the title for today is A Syncopal Episode in a Collegiate Football Player. I would be remiss if I didn't give special thanks to Michelle Galvin, our Assistant Athletic Trainer at UC, Dr. John Devine, who is our head team physician, and Dr. Susan Braley, who is our Director of Musculoskeletal Radiology at University of Cincinnati. This core group of people were integral parts in the management of this situation and the overall good outcome of our student athlete with this situation. The learning objectives for today are going to be to understand and recognize signs and symptoms of pulmonary embolism, understand and recognize the etiological factors for pulmonary embolism, and then also to understand the uniqueness of unprovoked pulmonary embolism. So our case today occurred in one of our football players who was a 20-year-old male African-American athlete. He was a sophomore linebacker for us at the time, 6'2", about 218 pounds, and he was sickle cell trait negative. Previous medical history for this individual was relatively short, unimpressive. He had a concussion without loss of consciousness in 2014, which was in high school. Also, he had a right ACL reconstruction using a hamstring autograft. I believe that was his senior year. That ended his senior year before he got to us. And then in the 2017 season, he had a left shoulder subluxation, which we treated conservatively successfully and were able to avoid surgery. One of the quotes that I kind of use often with my staff, when we're kind of going through our differential diagnoses, listen to histories, trying to, get an understanding of what, issue is being brought to us by our athletes, is when you hear hoofbeats, think horses, not zebras. And I can't remember where I picked this up at, but as you're going through these injuries, going through illnesses, whatever it may be, basically when you are going through that kind of first various steps of taking the history or trying to gain an understanding of what has happened or what is occurring, it's usually prudent to kind of go with the things that are kind of path of least resistance. Go with the diagnoses. Go with the things that you commonly see, and can rule those things out first, versus going to kind of the worst case scenario, or going to something that just doesn't happen as frequently, or something that you've never seen before. Primarily the primary function for that is you can end up doing a lot of unnecessary testing, a lot of unnecessary diagnostics that may lead you down a wrong path, or quite frankly, rack up some substantial medical bills and stuff like that. So target the things that are common first. To kind of set the scene, in mid-December 2017 and really continuing all the way till early February 2018, we had a pretty impressive, high incidence of positive influenza A tests, within our athletic department. And this included football. It was not exclusive to football. We saw it in our swimmers and divers and lacrosse athletes, and really kind of across that whole group of athletes that really started from December and carried itself into February. So it was something that we collectively as the athletic trainers were dealing with for not just a week or two. It was kind of a multi-week issue we were dealing with. This particular patient's roommate ended up being diagnosed with the flu early, not too far before his situation started to present itself. So that's one thing to kind of keep in mind as we go forth. But on January 15th, 2018, the patient presented to us with body aches, chills, sweat, night sweats type stuff, nasal and chest congestion with white to yellow mucus production. He did not have an elevated temperature or fever. We captured an oral temp at 98.4, and based upon his symptomology that he presented with, and in relation to the high incidence of flu that we had seen, by that point in time, we were very quick to prophylactically treat with Tamiflu, pretty much right from the jump, and then follow up with a test to see, if the athlete ended up, in fact being positive. So we started the prophylaxis of Tamiflu, and did the flu test, and it actually ended up coming back negative. And we had seen some false negative, flu tests, or at least that we felt. So it wasn't too uncommon, for us to go ahead and continue to treat his symptomology as the flu, just because of its prevalence. A couple weeks later, January 31st, he was seen for this persistent kind of like cough and congestion that just was kind of lingering. Otherwise, he felt normal. Didn't feel sick, didn't feel ill. Felt like he had kind of got over the bulk of whatever it was that he was dealing with. And, we just kind of wrote it off as post-viral cough. And we prescribed him a corticosteroid inhaler that he used for, a handful of days, week plus. And really just didn't see a whole lot of improvement with it. But, again, nothing that was alarming there. A couple days later, February 2nd, 2018, the athlete came to us again, just say, cough just isn't improving, and what's kind of next steps? What else can we do? So our team physician prescribed him a Medrol dose pack and a Z pack of zithromycin, just to kind of cover our bases in case that this had turned into a little bit of like a bacterial pneumonia. That we can go ahead and get that treatment, started and going. At this time, early February, he was, cleared to return to activity from the weight room. Was having no issues with lifting, cardio in terms of conditioning type work. He was, limited, but could really go as he could and as symptoms allowed. However, he did complain about a little bit of shortness of breath and a cough that kind of increased in productivity as the intensity of exercise increased. So it was something we just kind of kept our eye on. But again, nothing that seemed too out of place or too unreasonable for kind of the illness pathway that he had taken, and things that were continuing to persist for him. And then on February 5th, 2018, we were doing it was the activity for the day was an off-season conditioning session. This particular episode occurred while we were doing our dynamic warm-up. We were going, just as the dynamic warm-up goes, we start off, relatively slow, and then over the period of, 10 minutes or so, the intensity of that, ramps up as we prepare, their body physically for, greater activity. So as normal, as they're warming up, I kind of, walk around, just kind of checking on guys, asking some questions. Good opportunity for me to just get in a couple surveys of how everybody's doing. Just kind of off the cuff stuff. And I went up to him, and he made a complaint of, just feel a little lightheaded, just kind of short of breath, just kind of feel like the cough, just isn't, just it's still bothering me type thing. And I believe at this time they were doing like some walking, kind of like bent over, like toe touches, just working on some hamstring flexibility, mobility type stuff. And we get, I'm kind of walking with him, and we get to the point where he gets to the end of the line and stops. And he's telling me these things about his shortness of breath, and he's lightheaded, and I'm like, all right, you're, I don't know what you got going on, but you're done. This is starting to not make sense. We're gonna get you with that. We gotta figure something else out. And as I was saying these things and thinking them, he kind of gave me this, kind of weird, big-eyed look, and he actually collapsed and had a syncopal episode. And I was able to fortunately be right there and caught him, and then kind of, rode him down towards the ground and gently laid him on his back. By time he got to his back, just a matter of, seconds later, 2-3 seconds maybe, he was alert, looking up at me, and basically kind of had the, what just happened look. And I think even verbalized that. And I'm like, yeah, that's a great question. I would like to know, why you seemingly passed out as well. So I had our staff and students, grabbed, kind of our trauma bag, brought it over real quick, and went ahead and did some vitals right there on the field as he was laying there. Put a pulse ox on him. Initially it was in the low 90s, like 91, 92, and had a slightly increased blood pressure, but nothing that seemed to be, I would say, largely abnormal. Decided to give him a little bit of high flow oxygen. We have that readily available for us. We do have at the time we had a handful of athletes that were sickle cell trait positive, so we keep oxygen tanks with us pretty much at our fingertips if during conditioning sessions and practices. So gave him just a brief period of time of high flow oxygen, probably less than a minute, and very rapidly his SpO2 recovered to 98, 99, and his heart rate returned to normal as he was laying there. So I felt at the time it was safe. Got him up, walked him off to the side of the field, got him to the bench where he could sit down, and went ahead and called our team physician and kind of recapped the situation with him. And we both agreed that the low, relatively low SpO2 level, coupled with that the syncopal episode, was more than enough for both of us, that we wanted to go ahead and start to get him further worked up with diagnostics. So after consulting with our team physician via phone, we determined that we were going to go ahead. Michelle was going to take him over in our van, take him over to the medical center, and start to knock out a kind of a list of diagnostics that our team physician wanted. As we were preparing to take him, I still had that pulse ox on him, and Michelle had radioed to me and said, hey, the pulse ox is kind of doing something weird. He'll have, heart rate will sit in the low 70s, and then all of a sudden it looks like it bumps up to the 120s, and then it'll go right back down to 70s. So it seemed like it had a little bit of kind of erratic behavior, but he was still reporting to us that he felt, essentially normal, at that point, and was alert, breathing fine, no labored breathing, or seemingly no outward distress. But given kind of the weird nature of what we were seeing with that pulse ox, we decided, all right, hop in the van, go right now. Let's start getting this stuff knocked out so we can try to get to the bottom of what we got going on. So team physician initially ordered a chest x-ray, a limited chest CT scan, a D-dimer with blood work, and then also an EKG. You know, pretty much, you know, your basic testing if you have something that's cardiovascular, of cardiovascular concern. We did all these outpatient. You know, fortunately for us, we're blessed to have a medical center that is a level 1 trauma unit, and all of these, you know, services for us are really located under one roof in what's called our medical arts building. So she was able to knock these different things out on a couple different floors of this building, but within probably 30 minutes, all of these were able to get achieved. So as she and the athlete are waiting over at the building, kind of gave them the instruction like, hey, go ahead and let's get these tests done. We have our radiologist on standby to go ahead and look at the imaging stuff, and then we're gonna, you know, once cardiology gets done with the EKG, we should have a pretty good idea of what we got going on. So just stay there in case, you know, further testing needs to be done. And as we're waiting for some of those results to start, you know, coming up and getting correspondence with it, the chest X-ray comes back completely normal, no major concerns there. But one after the other, we start to get abnormal findings. The cardiology staff basically came out into the waiting room and was like, we need to see him again because his EKG was abnormal, and I'll show that on the next slide. And then the limited chest CT scan came back abnormal as well. And as the cardiology staff was talking to our assistant, that's when that correspondence from the radiology group came back in. And head team physician said, you know, we gotta get him over the ER and kind of elevate his level of care. So the EKG that they have on this gentleman, as you can see below, he was in normal sinus rhythm, but had findings that indicated a pos left atrial enlargement. There were some abnormal QR patterns that suggested right ventricular conduction delay. There was a prolonged QT segment, and just overall, you know, an abnormal EKG that warranted further evaluation. That QT C interval was 486. You can see that kind of in that second column from left to right. You know, about 4 or 5, you know, lines down. So 486 on QTC interval is actually a very long QT interval, and you know, something that kind of raised our concern there, obviously, and was another reason as to why we need to get him over to the ER and start to, you know, get to the bottom of seemingly what we have going on, which is you know, a bunch of abnormal findings. So with the initial blood work, the initial lab work that came back, he had a D dimer that was quite elevated, a troponin level which was elevated, and troponin is a cardiac muscle, you know, protein value that we look at. Basically, the greater that number, the greater the possibility there is of damaged cardiac muscle tissue. His CK level was elevated, which is an enzyme when muscle is damaged, and then his BNP level, which is a hormone produced inside the chambers of the heart during heart failure, and this ultimately signals the vessels in your body to dilate to start taking pressure off your heart. So all 4 of those lab values were elevated. And you know, with that positive D dimer, starting to be a little concerned about you know, some kind of thrombus, you know, located somewhere in his body. So the CT angio chest study that was done with contrast came back, and the findings there were the heart basically was enlarged. Right heart with right ventricular enlargement compared to the left. and the ratio on that was 1.4, and I'll explain that in the next slide. And then within the pulmonary arteries, he had an enlargement of the main pulmonary artery, measuring 4 centimeters in diameter, and then multiple filling defects of the bilateral lobar, segmental, and subsegmental arteries. And with these findings, there's basically concern for pulmonary embolism, and basically heart strain, saying that the heart is basically backfilling with blood and is becoming enlarged and is headed down the path of heart failure. So with that ratio I was speaking of, a positive finding for right heart strain is anything greater than a 1-to-1 ratio. So the right ventricle and the left ventricle should be synonymous in terms of size of diameter, and the right ventricle, as you can see there, was 63 millimeters across, whereas the left ventricle was only 39. So that was a positive finding for right heart strain. This next slide is an axial cut of his chest, and the measurement you see there is 39 millimeters of the main pulmonary artery, and anything greater than 33 is basically crossing over the normal kind of transverse cross-section limit of that main pulmonary artery. So anything north of 33 basically indicates pulmonary hypertension, which was a finding we have here. So what this image illustrates is basically how pulmonary hypertension occurs. And if you look at basically the heart instead of lungs on the right, you can see where the arrows are pointing of some kind of constriction of the pulmonary arteries, due to whatever it may be. In this case, obviously, it was a pulmonary embolism. And as the outward blood flow basically gets blocked or constricted, coming out of those pulmonary arteries, the backfilling of that blood occurs, especially in that right ventricle. And you see that right ventricle basically start to get bigger and bigger and bigger, and as it loses its ability, for the outflow of blood to exit in towards the lungs. And this is a 3D reconstruction of the CT angiogram that we got, and fortunately, I've got a radiologist that's absolutely awesome, and is able to take all these images and put arrows and make it basically make it make sense for me. And what you can see here is the 3 different green arrows basically pointing at locations of where the pulmonary emboli were. So not only did he have one embolism, pulmonary embolism, he actually had multiple, really in both sides of the lungs, which was obviously very problematic. This next slide is a axial view of his chest via CT scan, and I have the various parts of the heart labeled. The AAO is ascending aorta, DAO in red is descending aorta, and then within blue you have the main pulmonary artery, and then the 2 branches where it branches off into the right pulmonary artery and the left pulmonary artery. And the green arrows indicate basically kind of like the black little blobs, if you will, are the actual pulmonary embolisms themselves, and you can see those pretty explicitly on those views. This next slide is just another axial cut, a little further distal or inferior, and demarcated here with the green arrows. You can see, especially in that right pulmonary artery, you can basically see that embolism, smack dab in the center of the artery itself. And then over in the left pulmonary artery, you can see a series of black circles that indicate the embolisms over there. going further down and looking further out into kind of the segmented branches of the arteries and lungs, you start to see even more green arrows, indicating further, emboli, located within this individual. And then on this one is a coronal cut, and then the green arrow there up in that right pulmonary artery. You can see how the rest of the artery is nice and white, basically through and through. And then as you get to the end of that particular branch of the right pulmonary artery, you have that, again, kind of that black abnormal shaped kind of like blob right there, blocking off that flow. And then again, further out into the periphery of the lungs, more arrows indicating more emboli, blocking the blood flow right there. And then same thing in this one, just the opposite side of the lungs in the left pulmonary artery, kind of like a long skinny embolism there, and then another one down just a little bit lower, marked by that second green arrow. And then again, here's another indication. So as you can see with those last handful of slides, a shocking amount of embolism, located in both sides of the lungs. So with the CT scan, obviously indicating very clearly that there's embolism everywhere, the new working diagnosis is multiple submassive pulmonary emboli involving both lungs and mainstream bronchi with right heart strain, as you can see in those last couple of slides. So pulmonary embolism assessment flow chart, anytime you have a suspected pulmonary embolism, after a clinical assessment, the first thing you do is that D-dimer test, and then based on those results, you're either going to rule out the pulmonary embolism, or you're going to get further imaging. And in the case of our athlete, that D-dimer test did come back elevated, and that pulmonary CTA came back with evidence of with emboli in both lungs. So he did and does meet the criteria for pulmonary embolism. So the next intervention we had is immediately, walked him straight over to the emergency room. Our team physician called ahead to give them the update of, the knowledge that we now had with the abnormal EKG and the abnormal findings on the CT scan. With intake there, they did just a routine set of vitals. His blood pressure at this point was 160/92, and he was still having on their monitors kind of this inconsistent heart rate that would get a little bit tachycardic, go down kind of like to a normal resting rate, kind of bounce back up. So it was kind of erratic. But I think the very interesting thing about this, really this entire case is he didn't feel bad. Like he really didn't feel ill at this point, despite having his blood pressure elevated. He was sit there, talking to the staff, able to converse, and not really in any outward sign of distress. From there, the ER staff immediately admitted him to the cardiovascular ICU unit for thromboembolic treatment, and that was kind of our next step. So the next intervention that he underwent was a 12-hour ECOS endowave catheter procedure, which at the time I knew absolutely nothing about, but now that I've been through this situation, it's actually fascinating how they use this technology to basically try to get him out of the woods with those blood clots everywhere in his lungs. And what it is it's a basically an ultrasound assisted catheter that goes up into your lungs and drips TPA, which is tissue plasminogen activator. It's a protein, that's involved in blood clot breakdown. So they had a little TPA drip that went into both sides of the lungs, and then the catheter that I'll show you on this next slide basically has ultrasound waves that emit from the catheter to kind of help basically break up and dissolve the thrombus, and ultimately restore normal blood flow. So the insertion point of this catheter was down in his thigh in the femoral vein, and the reason for 12 hours is by protocol of this unit and this company, for each lung that you have a pulmonary embolism, you do a 6-hour treatment. So since he had both lungs involved, he had to do a 12-hour treatment where he laid pretty much perfectly still, supine on his back, until the treatment was done. Couldn't, I think they had to do a urinary catheter because he wasn't able to go up and go to the bathroom, and had to be NPO during that entire time. So this is kind of what the catheter itself looks like. It's goes up and has this ultrasonic core, different areas where it emits the ultrasonic waves, in addition to the steady TPA drip. And then here's an illustration of them, basically working, their way up into his heart and into his lungs. And then you've got each catheter that basically kind of goes into each pulmonary artery, and does its magic with the TPA drip and in the ultrasonic waves. So common signs and symptoms of pulmonary embolism are dyspnea, pleuritic chest pain, cough, fever, a little bit of bloody, spit up or sputum, syncope, can be unilateral leg pain, which are basically signs of DVT, and really he didn't have any of outside of the cough at that point in time. Didn't really have any of these signs and symptoms. Did have the syncopal episode, but didn't have any leg pain, really that was present at all. And around 80% of patients with pulmonary embolisms have signs of DVT or deep vein thrombosis. So something to further keep in mind is, kind of as we go forward. So pulmonary embolism is a potentially life-threatening condition, and in severe cases, the occurrence of circulatory collapse and cardiac arrest may result in sudden death. Early fatality occurs in up to 15% of patients. Therefore, a rapid diagnosis is very critical. The diagnosis of PE, however, may be missed because of its nonspecific clinical symptoms, which I think we can definitely attest to in this situation. And similar to deep vein thrombosis, PE is often asymptomatic. And in approximately 30% of cases, pulmonary embolisms are completely idiopathic and unprovoked, and you don't have a true reason for why it occurs. But I think the thing that really kind of struck me as we were going through this situation is the staff in the cardiovascular ICU. Were really kind of blown away with how he looked and how he, in terms of just seemingly overall health, how he appeared to them. They said, most of the patients that we get on this floor, with the extent of pulmonary embolism that he's dealing with, they do not look very well at all. They look, very sick, very unwell. And a lot of them basically look like they're in the process of dying, because often they are, with how how bad and how much embolism and clotting there was within his lungs. So after that 12-hour session on the ECOS unit, he was switched to a heparin IV drip, which lasted for 48 hours, and then Once that was discontinued, he was switched to an oral anti-coagulation medication. And from what I recall in the ICU, even after they did that 12-hour period of that intervention, and then the next 48 hours of the heparin, there was still kind of like a 2-3 day window where they really felt that he wasn't out of the woods at that point, because once you start to break up the clots and start to dissolve them, the next big concern is one of those breaking free and eventually making it to your brain and causing a stroke. So he remained in the ICU for quite a few days, and basically for strict monitoring to make sure that the situation for him didn't go downhill quickly. So after 3 days, he was discharged from the ICU, but I believe, if I recall, had to stay admitted into the hospital. Was just on a step down level, because there was a lot of follow-up testing that they wanted to do with cardiology, with hematology, and at this point now try to kind of get to the bottom of why maybe this occurred. So they ordered a venous Doppler ultrasound, an echocardiogram, and also a pretty robust lab panel with hematology. So as we get the Doppler ultrasound of his legs, it came back, sure enough, showing that he had multiple DVTs in both legs. Right leg was worse than the left. He had acute occluding DVTs in the distal femoral, popliteal, gastroc, and perineal veins, and then in the left leg he had occluding DVTs in the perineal veins. And just bizarre how his legs were completely asymptomatic, no major swelling, no point tenderness or anything like that. Yet he had clots basically all over the place. We also did the cardiac echocardiogram, and that came back showing severe right ventricular and right atrial dilation. Again, from that kind of like that backwash of pulmonary hypertension, not allowing that blood to exit the way that it should. So we get again a robust panel of blood work, per our hematologist, and the reason for all of these basically are to look at common reasons for someone to have a coagulopathy, whether it be a mutation or a protein deficiency that prevents against excessive clotting, and all of these labs actually came back normal or negative, which was pretty unique about the situation. Often when you have somebody that has clots all over their body, it's like a factor V mutation, or they have some kind of protein deficiency or antithrombin 3 deficiency, where something within their blood chemistry or their blood makeup just isn't working the way that it's supposed to, or there's something that's mutated. And in this case, all of this stuff came back negative. So we really started scratching our heads as to, all right, like why have we seen this? Why is this occurring in this young healthy athlete? Some common risk factors for DVT and pulmonary embolism, again, are blood deficiencies. You see it in blood type A more than others. Someone that had a burn, or indwelling venous catheters, pacemakers, someone's on chemotherapy, anybody that has a history of DVT. In my time at UC, I think we've had a couple female athletes that we've dealt with blood clots before, and those seem to kind of point back to oral contraceptives. Obviously, this wasn't the case in our male athlete. You see them sometimes after big fractures or surgeries, malignancy, prolonged bed rest, or sometimes maybe you see it like in a really long car ride, or a long flight maybe, but none of those fit the bill. No acute trauma didn't have any, at this point in the season, we weren't hitting each other. There was no contact or anything like that. So, honestly, we were able to rule, all of these out, which, kind of led to, just more of that, confusion as to why, why this athlete was dealing with what he was. So looked at family history to see if there was anything there, and sure enough, there was, some familial history of DVTs. His brother had a DVT that was relating to his Hodgkin's lymphoma treatment. He had a first cousin with a DVT after an ankle sprain. He played collegiate football for LaGrange, and that was, kind of an interesting thing there. And then he had a great aunt with a history of blood clots that the family, couldn't, really identify for any of these three, a singular or particular reason as to why, they occurred. Nobody else in the family, had, I think that lab work done, but for this gentleman, again, we didn't find any deficiencies or mutations or anything like that. So, with the kind of the extensive workup at this point, our new diagnosis is unprovoked bilateral pulmonary embolism. And the unprovoked component, from what I have now learned, was really kind of a unique designation where we don't have a good reason as to why this happened. And in the next slide, I'll explain kind of that further. But kind of jumping forward, because of this diagnosis, it was our decision as a medical staff to end up medically disqualifying him from competition, which the athlete, was very reasonable about, but did take it hard, and asked, eventually very, kindly and politely, and we actually, helped offer it up, was a second opinion just to get, somebody else in the field, a chance to hear them out and see what what they have to say. So we assisted with getting our athletes set up with Dr. Mole and Dr. Berkowitz down at UNC Chapel Hill. After kind of reaching out to some colleagues across the country, these were the names that kind of came up in hematology, as it relates to athletics. And what they ended up telling us is that in men with unprovoked venous thromboembolism, they have a 30% chance of reoccurrence over 5 years if they discontinue anticoagulation therapy after a few months. And with that high risk, long-term anticoagulation is recommended. And this is thus kind of the genesis for why we ended up medically disqualifying him. The conversation I had with him is, the 30% chance may not seem like a very large percentage, but it's a hell of a lot bigger than I think the risk that any of us want to go back through or put you through, especially if there's something, medication that you can take that can seemingly prevent this from happening in the future, especially after talking to the cardiovascular ICU staff and then them saying, really truly how, ill he was, although he may not have outwardly appeared that, the situation that he was dealing with on the inside of his, heart and lungs was one that was dire. And, luckily for him, he was, a well-trained athlete and probably helped him deal with that whole situation. So one of the things that was discussed with the staff at UNC Chapel Hill was kind of this on and off anticoagulation, kind of matrix that they were studying currently at that particular given point in time. And what they would look for there is if the athlete basically has or shows a negative D-dimer, that they could go through kind of this, paradigm of taking their medication, not taking it again, not taking it, as they work their way through a season, you may actually be able to, have them, participate successfully. But as we sent our athlete down there, they were starting to, kind of wrap up the study, and it was looking at this, matrix that they had in determining who would work for, who would not work for. It seemed to only be predictive in women for some reason. And then, they were saying with men, a risk still remains that, basically is substantial enough that, they're recommending against, using D-dimer as part of the decision-making process. And, again, if you're going to be anticoagulated and on, basically blood thinners for the rest of your life, someone playing a collision sport like football is obviously very much ill-advised. So as our athlete is going through this, it comes out, I think later that year, it looks like July, that there was a Tennessee football player that was cleared to play after being diagnosed with blood clots. And our athlete subsequently, actually, I think ended up befriending this individual on social media, and was kind of asking him about his situation with it. And it's my belief, I think somewhere down the road, that this individual in Tennessee ended up having a reoccurrence of blood clots, and was, I believe, attempting to do that on again, off again anticoagulation therapy. So that may have been a situation where that didn't quite work the way that it was intended. So the long-term plan for our athletes, at this point, was long-term anticoagulation therapy. He is going to take the medication Xarelto at 20 milligrams a day. And with insurance, fortunately, he was, a student athlete for us, and we were covering it. But with insurance, that Xarelto prescription was running about $460 a month. So it was, definitely an expensive venture, but one that we were more than willing to take on and make sure that he had the medication that he needed. And once he graduated and moved on, we assisted him in finding adequate medical insurance. That way he could keep up the anticoagulation therapy treatment without kind of breaking the bank. But we had continued some thrombophilia workup, and to date, all of that stuff was still negative. And we also worked him up with cardiology and hematology, just as kind of consistent follow-ups over the next 2-3 years to make sure that everything was returning to normal in terms of heart and lungs, which it did. So pleased to report that with a situation that otherwise I think was scary, that he has made a full recovery and heart and lungs and how that all worked out. So thanks for listening to this case study. Again, I think it's it was unique in nature, in kind of how it initially presented itself, seeming as a just a kind of run-of-the-mill illness, again, that just didn't quite improve the way that you had expected, kind of with that persistent cough, that type of thing. So as you're out there providing care to your athletes, if you find yourself in a situation, or you have a situation present itself that just doesn't seem to make sense, or doesn't seem to be kind of coming to a resolution the way that you think it might, that's when you may start to put up your antenna, about the uniqueness of maybe the situation that you're dealing with, and start to look down some other avenues that you otherwise wouldn't. That way you can make sure that the outcome is as good as it possibly can be for your patient. If there's any questions, please feel free to email me. That's my email address right there. Always willing to share whatever knowledge I have, and if there's a way I can be of assistance to any of you, please feel free to utilize that and reach out. Okay. Other than that, thank you for the opportunity, and good luck with all of you and your seasons and this year, and hopefully it's one of great health and great success. So thank you.